Hey everyone, and welcome to another episode of Rebelcast. My name is Will Smith. Today we have a very interesting article from the New England Journal of Medicine about pneumonia. It's that time of year where these types of patients are bound to end up in our emergency department. So I think this is something that's going to be very relevant to our medical practice. Before we get started, I'd like to introduce my co-host, Dr. Marco Papersi. Marco, how's it going, buddy?
How's it going, Will? I'm always happy to be on Rebelcast, hanging and talking some evidence-based emergency medicine with you. For those who don't know me, Marco Propersi, I'm APD and Vice Chair of Emergency Medicine at Vassar Hospital in Poughkeepsie, New York.
Like I said, my name is Will Smith. I am in my intern year of attendinghood in Northern California. In addition to contributing to Rebel EM, I'm the EMRAcast Podcasting Fellows. Today, we are going to be talking about corticosteroids in the severe community-acquired pneumonia. It's the COD study, and it takes a look at using steroids in patients with very severe pneumonia. Marco, why don't you give us a little bit of background before we jump in?
Absolutely. Community-acquired pneumonia is an infection in the lungs, and it can lead to pulmonary and systemic inflammation, resulting in sepsis and organ failure. It can cause death. Clearly, it can cause impaired gas exchange. Corticosteroids, they have excellent anti-inflammatory and immunomodulatory effects. That's a tough one to say. These effects could mitigate some of the inflammation caused by that pneumonia. And there have been several randomized trials which have showed positive effects when glucocorticoids are used in patients with community-acquired pneumonia. But except for one trial, none really showed a difference in mortality.
The paper is written by Dequin, Cunha, and Mezziani et al. Hydrocortisone in severe community-acquired pneumonia out of New England Journal of Medicine. What was the clinical question that we were trying to ask with this, Marco?
So, Will, the investigators of the Cape Cod trial, they were trying to determine in adult patients with severe community-acquired pneumonia admitted to the ICU, does early hydrocortisone treatment compared to standard therapy reduce mortality at 28 days?
Can you tell me a little bit about how they did that? What exactly they did for the study?
They conducted a phase 3, multi-center, double-blind, randomized, controlled superiority trial. And they enrolled patients from 31 ICUs in France. Patients who were admitted to the ICU with severe community-acquired pneumonia were randomized in a 1-to-1 fashion to receive either hydrocortisone infusion or a placebo. And the study was funded by the French Ministry of Health.
What were some of the inclusion criteria for the patients?
The paper included adult patients greater than 18 years old. They had to be admitted to a participating ICU with severe community-acquired pneumonia. And the pneumonia diagnosis was supported by both clinical and radiographic criteria. And they used predefined criteria to determine the severity of the pneumonia. And you can go ahead and read the post to get more specific information on that.
There was also quite a few specifics for exclusion criteria, but in general, nobody was included if they had a DNR, if there was a decision to withhold mechanical ventilation, if they had been on mechanical ventilation within the past 14 days. And then it also seemed like anyone who had influenza, septic shock, aspiration, other infectious disease potential like TB, fungal infection, viral hepatitis, all those type of patients were also excluded and not included in this trial.
I think the gist here was that they were just trying to exclude any patients who would have been clearly helped or harmed by corticosteroids, right? If they know that steroids are going to help or harm them, then it's like, well, it's going to kind of muddy the data a little bit. So they knock those patients out.
Marco, why don't you talk a little bit about the interventions for this study as well as what they did for the control group?
Sure. So what they did is investigators infused hydrocortisone 200 milligrams daily, continuously for 4 straight days. Now, on the 4th day, the medical team used predefined criteria to decide whether to continue administering the hydrocortisone for a total of 8 days or whether they were going to extend it to 14 days. And that really depended on whether the patient's condition was improving sufficiently based on those criteria. Now, if we look at the control group, they administered normal saline via continuous infusion in the exact same regimen as the hydrocortisone group.
Primary outcome for this was very simple: death from any cause by day 28. Secondary Death by any cause went out to 90 days. They also looked at length of stay in the ICU, and they also took a look at the amount of time that patients required on the ventilator. Marco, can you talk a little bit more about the types of patients that were involved in this study?
Let's start with patient enrollment. They looked at about 6,000 patients that they assessed for eligibility, and they excluded more than 5,000 patients. So in total, 800 of the enrolled patients were randomized into the trial. 401 were allocated to the hydrocortisone group, another 399 to the control group. And 795 patients were included in the primary analysis. One patient died in the hydrocortisone group before they received any treatment. Two patients withdrew consent, and two did not have legal capacity to give consent in the first place after they were actually enrolled and randomized. And if we look at a little bit more of the specific metrics and some of the baseline demographics, lots of these patients were on respiratory support. And it's important to just highlight some of the characteristics. 22% were on invasive mechanical ventilation. Another 22% were on non-invasive mechanical ventilation. 42% were on high flow nasal cannula, and 14% were on a non-rebreather. The median interval from hospital admission to ICU was 5 hours, and the median interval for ICU admission to initiation of the trial agent was about 15 hours.
With all that said, what was the primary outcome? And then let's move on to the secondary outcome.
The investigators achieved a 6.2% 28-day mortality rate in the hydrocortisone group compared to a nearly 12% mortality rate at 28 days in the placebo group. And that was actually statistically significant. Now, if we look at the secondary outcomes, some of the important ones were by day 90, mortality was 9.3% in the hydrocortisone group and 14.7% in the placebo group. There was an absolute difference of about 5.4 percentage points. If we just look at the patients who had not received any mechanical ventilation on baseline, there was about 450 of them. 18% of those patients in the hydrocortisone group went on to have invasive mechanical ventilation. When if we look in the placebo group, nearly 30% of those patients went on to be intubated and have mechanical ventilation. That equals a hazard ratio of 0.59. Now, if we look at patients who received no invasive ventilation at baseline, the incidence of invasive mechanical ventilation before 28 days was nearly 20% in the hydrocortisone group and 30% in the placebo group. Now, if we look at vasopressor therapy, there are about 700 patients who had not received vasopressor therapy at baseline. If we look at the incidence of vasopressor initiation in the first 28 days, 15% of patients in the hydrocortisone group went on to receive vasopressor therapy, while 25% of patients in the placebo group went on to receive vasopressor therapy. There really was no difference between either group in adverse events between patients who were receiving hydrocortisone therapy versus placebo.
Like all studies, there are going to be strengths, there's going to be weaknesses. One of the biggest strengths in this study is the fact that it was double-blinded, it was placebo, it was randomized, and it was also multi-centered. That minimizes potential bias, and then the fact that it's multi-centered will increase the validity and make it more generalizable across multiple populations. In addition to that, although it was a multi-center study, the randomization was centralized, making the treatment arm allocation equitable across all of the different centers. Now, when you look at what the primary outcome is, and I think this is something that is very clinically relevant and what we care about, essentially they answer the question, but did you die, right? We were looking at all-cause 28-day mortality, and I think that that's a really important thing to look at when we consider whether this is going to be something that we put into our practice or not. Also, the fact that this was registered at clinicaltrials.gov allowed for transparency. We can replicate the study and people can really analyze how well that this was actually done. We had mentioned that this was double blind. Additionally, the medication bottles were all labeled the same way, whether it was placebo or it was not. Again, that helps reduce bias. And I think it's also important to note that because this is a respiratory illness, the enrolled patients were representative of critically ill patients. The cohort that was on mechanical ventilation was about 45%. So they made up a pretty good contingency of this population. With all that said, Marco, can you talk about some of the limitations of this study?
Absolutely, Will. So the study was conducted exclusively in one country. That's going to limit external validity. Are patients in France, are they reflective of all the patients admitted in the entirety of the world who are in the ICU with severe community-acquired pneumonia? Now, it's tough to say that. They also implied some very, very strict inclusion criteria. And like we said, I think they assessed 6,000 patients and excluded about 5,000 of them, right? Clearly, that's going to introduce some selection bias. They also estimated a mortality rate of 27% for the placebo group and 20% for the hydrocortisone group, but they actually observed a much lower mortality rate of 12% and 6.2%. So that may impact the validity of the study's findings. Now, although they calculated a necessary sample size of 1,200, they only were able to enroll about 800 participants, and that's going to affect the power of the study. They did enroll patients from 31 centers, but it's really important to highlight that 45% of the enrolled patients just came from 4 ICUs. So that introduces the possibility of co-intervention bias. Perhaps these 4 ICUs are really good at treating severe community-acquired pneumonia. It's going to limit the generalizability to other institutions because it's not as broad, the patient population as not as diverse as it seemingly appears. 70% of the enrolled cohort are men, and that's probably pretty typical of patients who are afflicted with community-acquired pneumonia in the first place, but it does limit the generalizability of these findings to women. The average age was 67 years old. Again, also probably pretty typical of the patient populations who's going to be diagnosed with pneumonia, but it does limit the generalizability to younger patients. There were also some important baseline demographics which we really have to mention because it appears that, at least in some instances, perhaps the placebo group may have been a little bit sicker. Participants in the placebo arm had a median pneumonia severity index score of 130 compared to 127 in the hydrocortisone arm. Now, that doesn't sound like much, but that actually splits them into 2 separate categories. Patients less than 130 are in pneumonia severity index category 4, which has a 10% mortality, while pneumonia severity index score of 130 is technically category 5, which has a 30% mortality. That right there, those 3 little numbers, that small difference actually indicates a pretty big difference in mortality. One other important consideration that there were some differences in the pathogens that were identified in the hydrocortisone group. There were more patients in the placebo arm did not have a pathogen identified compared to the hydrocortisone arm. In these pneumonia studies, sputum culture is not always the most reliable, so even patients with very clear-cut bacterial pneumonia may not have a positive sputum culture. But that does raise a suspicion on whether or not some of these patients actually had another condition, like some viral pneumonia, perhaps. The trial was stopped early due to benefit. And we know that trials that are stopped early for benefit could potentially overestimate the study results. While patients received respiratory support, supportive care, and antibiotics at the discretion of the medical team, the specific interventions outside of the study intervention were not really well documented. So again, we have no idea whether patients in these 4 ICUs were just treated much more aggressively. Perhaps it was a tertiary care center with 24-hour ICU care, and some of these other hospitals could have been community settings without 24-hour ICU care. And then the other thing, we mentioned this about influenza. The search for pathogens was left up to the discretion of the medical team, so that introduces variability in the diagnostic process. And lastly, 75% of patients did not actually complete the treatment course of hydrocortisone therapy. So again, that's going to introduce some questions about the actual validity and the efficacy of the intervention.
Looking at the population where hydrocortisone was used and then comparing that to where it wasn't, it looks like there's some potential benefits in corticosteroids to severe community-acquired pneumonia. But it also looks like it really depends on several key factors. Can you talk about a couple of those?
Firstly, I think it appears, based on the preponderance of evidence, that corticosteroids, they may benefit pneumonia, but it's most likely in only the sickest patients who require ICU admission and have no contraindications to corticosteroids in the first place. So this is probably a much narrower population than we think. Now, next, corticosteroids, again, they may be beneficial, but the magnitude of this is probably not humongous. It's probably not as big as they got in this study. Demonstrating a significant reduction in mortality with a single medication is really, really difficult, especially in critical care setting, because a lot of these patients, they're heterogeneous and there are lots of factors that go into their critical illness and whether or not they improve or get worse or live or die. Next, The benefits for corticosteroids in severe pneumonia, they're most likely associated with really early treatment. Like in this study, they had to be treated within 24 hours, which was different from some of the other studies which did not see a benefit. And if we look on some of the secondary analysis, CRP is something that we don't routinely check in the emergency department, but what they found is they found a benefit of corticosteroid therapy in patients with very high levels of CRP exceeding greater than 150. We know that this corticosteroid therapy is known to attenuate the inflammatory response. So in patients with a significant inflammatory response, corticosteroids may be more effective. But it's hard. We need more research to identify these specific subgroups and further study them to determine whether or not these differences we found or these trends, are they just statistical noise, or are they in fact truly statistically significant benefits which may help our patients?
Some people like words and other people like numbers. So let's take a look at the numbers and statistics and see what we can derive from this study. It looks like early hydrocortisone treatment significantly reduced the 28-day mortality in severe acute community-acquired pneumonia for patients that were in the ICU. So 6.2% versus 11.9%, so almost 12% in the placebo group, which was consistent across all secondary outcomes. Additionally, the relative risk reduction for reduced risk in the treatment group, so those receiving hydrocortisone, compared to the placebo group, was 47%. Essentially, what this is saying is that you only need to treat 18 patients in the ICU with community-acquired pneumonia with hydrocortisone to put one of those patients on the other side of the 28-day mortality when compared to the placebo group. But like all things in medicine, there is a bit of an asterisk, right? So the fragility index of 6 cautions that the benefits that we see are hinged around relatively few events. So we need to take this into consideration.
I really like the fragility index because sometimes when you have these trials and they tell you that something is statistically significant, what you really want to know is, what is the robustness of the data, right? So the fragility index tells us that if we just switch around a couple patients from one group and put them into the other group, you see here it really just changes the total outcome of the study from a positive one to a negative one. And the higher that number, it's really important. The larger the fragility index, the more robust and the more valid the results are going to be, right? So 6 is a pretty low number. That makes us at least beg the question on whether or not this is this a true finding, or is this something that's just due to chance, or is this just something in the methodology based on some of the limitations that we already spoke about?
I think if you even take that a step further, is we're talking about patients in the ICU, right? These patients are much more prone to have many different things wrong with them. And so being able to control for a ton of different variables like really isn't possible in the ICU. It's very, very difficult. So I think you're right. That fragility index is really important with this. All right, Marco, can you talk to us a little bit about selection bias with this study?
I think that's a really important topic. If we look at this study, we already kind of mentioned it, that they assessed 6,000 patients and only included around 700, right? So it tells you that they were trying to exclude anybody that might be helped or harmed from corticosteroid therapy, but that's going to clearly introduce some selection bias. If we look, 86% of the patients initially screened were excluded from the trial. When we look at some of the selection criteria and the exclusion criteria, for example, they excluded patients who they suspected of having aspiration pneumonia. Now, if we take a step back and we just see, like, how do we diagnose aspiration pneumonia? I mean, mostly it's just based on a medical history and a classic x-ray pattern, but some of these patients may not be able to tell you that they vomited, and their x-ray pattern may not be all that suggestive. It doesn't necessarily mean that it's not aspiration pneumonia, but there's not really a definitive diagnostic test. Now, if you look at the supplementary info, they talk about septic shock as an exclusion criteria, and 25% of patients were excluded for septic shock. But if we look at the supplementary info, the classification of hypotension of septic shock was at the discretion of the treating team. If we consider that 45% of patients enrolled required positive pressure mechanical ventilation, that's a type of treatment modality that may include sedation, which both of those things, mechanical ventilation and sedation, could lead to hypotension necessitating vasopressor therapy. So again, this just introduces questions about the methodology and the exclusion and the selection bias. I think also if we take a look at the patients who were diagnosed with influenza and their testing, as we said, they left testing up to the discretion of the treating team. And it looks like there was about 4% positivity rate in both groups, but they really didn't tell us how many patients they tested in each group and whether or not it was the same. We just don't know if they tested every single patient, whether these things would be the same. Because remember, one group didn't have the same identification rate as far as pathogens as the other. So that begs the question on whether or not there was something else going on and not bacterial pneumonia. I think really importantly, though, we kind of alluded to this or spoke about it, is that the placebo group had a much higher percentage of patients with category 5 pneumonia severity index score. And as we said, those patients carry a mortality rate of 30% compared to category 4, which carries a mortality rate of 10%. So some of this mortality benefit could be just due to the fact that the placebo group was more sick at baseline than the hydrocortisone group.
All right, Marco, I think it's time to bring this home. We've talked about all the different numbers, statistics, what's included, what wasn't included, how strong of a study this was, what was the author's conclusion, and ultimately, what is our clinical conclusion on this?
Yeah, let's take it home. The authors concluded that among patients with severe community-acquired pneumonia who were being treated in the ICU, those who received hydrocortisone therapy had a lower risk of death by day 28 than those who received placebo. But I think our conclusion is somewhat congruent, but a little bit different. And I think the Cape Cod trial, the findings suggest that administering corticosteroids within the first 24 hours can significantly reduce mortality in severe community-acquired pneumonia patients admitted to the ICU. But it's worth noting that 75% of patients enrolled didn't complete the treatment protocol. And there were some statistical variations among different subgroups, which will require further investigation. Nevertheless, I think the best available evidence supports the conclusion that early corticosteroid administration can reduce mortality in severe community-acquired pneumonia patients in the ICU. So the clinical bottom line is early administration of corticosteroids can reduce mortality in severe community-acquired patients admitted to the ICU.
All right, Marco, thank you so much for taking the time to go over this today. And thank you for all your hard work in putting this post together. If you guys want to hear more about this post, read more about this post, we have both the article and Marco's post linked at rebelem.com. Just search for the Cape Cod trial. Thank you so much for joining us today, Marco. We appreciate your time.
Always a blast, and thanks for listening. Tune in until next time.
All right, take care, buddy.